Imagine a majestic horse, a picture of strength and grace suddenly just wasting away.
It's a difficult image.
Yeah. Its limbs falter, its mind seems clouded, and there's this mysterious unseen enemy stealing its life. Today, we're taking a deep dive into equine trypanosomiasis.
A global health challenge for horses, and one many people might not have heard of.
Exactly. And it really reveals just how cunning these microscopic threats can be, how they evolve to outwit our best efforts. Our mission here is really to cut through the scientific complexity.
Yeah, break it down.
And deliver the most important insights, giving you a shortcut to understanding this persistent, difficult adversary for horse owners and veterinarians worldwide.
And it truly is devastating. We see impacts from, insidious weight loss and profound weakness all the way to severe neurological problems and, yes, often death.
A complex and, like you said, fascinating story.
It really is. It's adaptation and survival on a microscopic scale.
So let's start peeling back the layers. Equine trypanosomiasis isn't just one disease, is it?
No, not at all. It's a group of infectious illnesses.
Caused by these tiny flagellated protozoa, Trypanosoma.
That's the genus. And they are tiny, maybe 14 to 33 micrometers long.
Which is, what, smaller than a human hair?
Oh, yeah. Much smaller. Microscopic.
Okay. So one of the first things you mentioned when we were prepping this identity crisis.
Ah, yes. That's fundamental. The scientific community is still, grappling with it.
Grappling with what exactly?
Whether Trypanosoma brucei, Trypanosoma equiperdum, and Trypanosoma evansi are truly distinct species.
Or just variations?
Or just variations, exactly. They're incredibly similar, genetically and morphologically. And they cause remarkably similar illnesses in horses.
And that's not just academic, right? This confusion has real-world consequences.
Oh, absolutely. Huge implications. This taxonomic ambiguity complicates everything. Diagnosis, for starters. Well, imagine trying to fight an enemy, but you're not even sure who it is. Tests designed for one might cross-react with another.
Or just miss the real culprit.
Precisely. Leading to misidentification, wrong treatments, ineffective control. It also makes it incredibly hard to track how these diseases are spreading. Epidemiological studies become much tougher.
So figuring out their identities is actually a critical research area.
Definitely. Foundational, really.
Okay, so it's a confusing family of parasites, and you said they have different travel strategies. Let's get into the different types.
Yeah, let's do that. Take Trypanosoma evansi, for example. It causes a disease called surra.
Surra. Okay.
And its geographical distribution is incredible. Africa, the Middle East, Asia, large parts of Central and South America. It's almost global.
Wow. How did it spread so widely?
Well, here's where it gets really interesting from an evolutionary perspective. It has adapted in a unique way.
Which is?
It's either completely lost or partially lost its kinetoplast DNA. It's key DNA.
Kinetoplast DNA. Remind me what that does for those of us non-biologists.
Think of it as like an extra bit of genetic machinery. Most trypanosomes need it to complete their life cycle, especially the part that happens inside an insect vector, like the tsetse fly.
Okay.
By losing this kDNA, T. evansi has essentially locked itself into its bloodstream form.
Locked in.
Meaning it no longer needs the tsetse fly to spread.
Ah, I see. So trying to control T. evansi just by controlling tsetse flies.
It's not going to work. Exactly. Control efforts have to be much, much broader. We're talking general biting fly management things like horse flies, stable flies.
Tabanids, stomoxys.
Right. Plus strict animal movement regulations, vigilance about iatrogenic transmission, contaminated needles, that sort of thing.
Okay.
And it can even spread other ways orally. Through vampire bats in some areas, venereally, even through milk.
That is a terrifyingly effective adaptation by the parasite, just bypassed its main vector.
It really is. Evolution in action.
Okay, moving to another key player. Trypanosoma equiperdum causes durine. This one's different, isn't it?
Very different. Durine is primarily a venereal disease, transmitted directly during mating.
Sexually transmitted, basically.
Yes. And another critical difference. Unlike T. evansi, which is often in the blood, T. equiperdum is largely a tissue parasite.
Hides in the tissues.
Prefers to. Which makes it incredibly hard to spot with a simple blood test. You often won't find it there.
So how does it persist then?
Asymptomatic carriers are key, especially donkeys. They can carry the parasite, spread it, without showing obvious signs themselves.
Sneaky. All right, then there's the Nagana group.
Trypanosoma congolans, Trypanosoma vivax, and Trypanosoma brucei.
These are the ones we typically link with tsetse flies in Africa.
That's right, primarily transmitted cyclically by tsetse flies in sub-Saharan Africa.
But there's a twist there too, isn't there, with TVVAX?
Yes. What's interesting is that TVAVX can also be transmitted mechanically by other biting flies, even outside of tsetse fly areas.
So it's also found ways to spread more widely.
It has. This adaptability contributes to its broader reach, makes it a persistent problem.
And you mentioned T. brucei. That one's particularly nasty for the nervous system.
Yes, it has a noted capacity to cause severe neurological disease in horses, which ties into the clinical signs we need to discuss.
Okay, so we've met the culprits, their sort of confusing identities, their travel plans. What actually happens inside the horse when they launch their attack? That hidden battle.
Indeed. And a pivotal survival strategy for these parasites, maybe the most important one, is immune evasion.
Avoiding the horse's defenses.
Exactly. Through something called antigenic variation.
Antigenic variation.
Yeah.
Sounds technical.
Think of it like the parasite wearing a coat. And every time the immune system recognizes that coat, the parasite switches to a different one.
A disguise artist.
Precisely. These coats are called variable surface glycoproteins, or VSGs. T. evansi, for example, constantly changes these VSGs on its surface.
So the immune system is always playing catch-up.
Perpetually challenged. It mounts a response. The parasite changes its coat. The response becomes ineffective. This constant switching. It directly drives the chronic, relapsing nature of the disease.
And that makes developing a vaccine
incredibly difficult. What do you target when the target keeps changing?
right. A huge challenge.
And beyond just dodging the direct immune attack, the infection itself can cause immunosuppression.
Weakening the horse's overall defenses.
Yes, making them much more vulnerable to other diseases or maybe less responsive to routine vaccines they might get. It compounds the problem.
Okay, so the parasite is dodging the immune system. What are the direct effects we see? You mentioned blood changes, hematological abnormalities.
Yes, those are very common, very consistent findings. The absolute hallmark of the disease is anemia, often profound anemia.
Lack of red blood cells. Why does that happen?
It's complex, multifactorial, really. You get increased destruction of red blood cells, both extravascular outside the blood vessels and intravascular within them. Hemolysis.
So the cells are just being destroyed.
They are. Plus something called erythrophagocytosis.
Okay.
Basically, the horse's own immune cells, macrophages, start eating the red blood cells.
Eating its own cells. Wow.
Yes. And there's also immune-mediated destruction involved. It's a multi-pronged attack on the horse's ability to carry oxygen.
Devastating. Are there other blood changes?
Yes, you often see variable changes in leukocytes,
Okay.
white blood cells. Sometimes leukopenia, a decrease, sometimes leukocytosis, an increase. Depends on the stage in the horse.
Okay.
And also thrombocytopenia.
Low platelets, affecting clotting.
Exactly. Reduced platelets, which are crucial for blood clotting, so potentially issues with bleeding.
Okay. Anemia, white cell changes, low platelets. Now, the neurological signs, you said this is often where it gets truly heartbreaking.
It is. These signs typically emerge later in the chronic stages. It happens when the parasites actually manage to invade the central nervous system, the brain, and spinal cord.
They cross the blood-brain barrier.
They do.
Yeah.
And that causes inflammation, encephalitis, and ultimately cellular necrosis. Brain damage, essentially.
What does that look like in the horse?
It can be a whole range of signs. Progressive weakness, stiffness, lameness, especially in the hind limbs. Incoordination, what we call ataxia, a staggering gait.
Difficulty moving.
Yes. You might see a head tilt, circling behavior, hyperexcitability, or the opposite, head pressing against things, paddling movements if they go down.
Are there more specific signs?
Sometimes, yes. Unilateral facial paralysis, one side of the face droops, a drooping lower lip. Even blindness can occur. And in severe advanced cases, seizures.
So if an owner sees their horse starting to stumble or maybe tilting its head, does that mean the damage is already done? Is it irreversible?
Unfortunately, often yes. Neurological signs mean the disease is advanced. The parasite is in the CNS. And that damage, it's often irreversible. The prognosis becomes guarded to poor at that point.
Which really underscores the need for early diagnosis.
Absolutely. Before it gets to the CNS, that's critical. And, for anyone listening, it's crucial to realize these neurological signs can look like other diseases.
Like EPM, equine protozoal myeloencephalitis.
Yeah, exactly. EPM, West Nile virus, even rabies in some stages. It complicates the diagnosis immensely and just hammers home the need for specific lab tests to confirm trypanosomiasis.
Okay. Beyond blood and brain damage, what other signs might show up? You said they can be quite varied.
They can. Intermittent recurrent fever is common, sometimes quite high, 39 to 44 degrees Celsius.
Just a high fever?
It is. Fluid swelling, edema is another sign, particularly in the legs and the lower body, like the belly or chest.
Yep.
Progressive wasting, lethargy. Severe weight loss leading to emaciation is very characteristic of the chronic form.
The horse just feeds away.
It does. Ocular lesions can occur too, conjunctivitis, keratitis, corneal opacity. Sometimes they can lead to blindness, and occasionally they might even be the first sign an owner notices.
Eye problems first.
Yeah.
Interesting.
And then there are these raised skin lesions, urticarial plaques, often over the ribs, maybe 5–10 centimeters across. Historically, people link them strongly to Durine.
But they can show up in surra, too.
They can, occasionally. Not strictly specific. Also, reproductive issues like abortion. Enlarged superficial lymph nodes, and lymphadenopathy and splenomegaly, and sometimes tiny bruises, petechial hemorrhages on mucous membranes.
That's a full long list, and a lot of it sounds quite general initially, which must make diagnosis incredibly tricky.
That's the word. Tricky,
Yeah.
especially early on. It's a real diagnostic tightrope.
Understanding what it does is one thing, but how do vets actually pinpoint it, given the sneaky parasite and the vague early signs?
It is a major challenge. Clinical suspicion is obviously the starting point, especially if you're in an area where the disease is known to occur, an endemic region.
Right.
But, as we said, the symptoms overlap with so many other equine diseases: African horse sickness, EVA, EIA, babesiosis, EPM, West Nile, rabies. The list is long.
So relying on signs alone is risky. High chance of misdiagnosis.
Very high risk of misdiagnosis or at least delay or treatment, which could be fatal. So you absolutely need a systematic diagnostic approach, moving beyond just clinical signs.
Okay, let's break down those methods, starting with, I guess, looking for the parasite directly.
Correct. Direct detection methods. The simplest is microscopic examination of blood smears.
Just looking under a microscope.
Yes, either a fresh wet film or a Giemsa-stained thin smear. This can work in acute cases when the horse is really sick and there are lots of parasites, high parasitemia in the blood. But its sensitivity is quite low in chronic cases, or when the parasitemia is low, which is often the situation. And remember, T. equipertum, the cause of Durine.
The tissue parasite.
Exactly. You'll rarely find that one in the blood smear.
So blood smears alone aren't very reliable. Have we improved on that?
Oh, yes. There are ways to concentrate the parasites. Buffy code examination is when you spin the blood down and examine the layer where white cells and parasites concentrate.
Okay.
Examining fluid aspirated from swollen lymph nodes can also sometimes reveal them.
Better, but still maybe not sensitive enough.
Right. For higher sensitivity, especially in chronic cases or for finding those silent asymptomatic carriers, laboratory rodent inoculation is still considered a gold standard by some.
Injecting mice or rats with the horse's blood.
Essentially, yes, with samples from the horse. The idea is that the parasites, even if scarce in the horse, will multiply in the highly susceptible rodent, making them detectable.
That sounds effective, but slow, maybe. And obviously needs lab facilities.
It is slow, yes. Takes time for the parasites to grow, and definitely needs a lab. So these direct methods, while useful sometimes, have significant limitations, especially for those chronic, low parasite cases or tissue-dwelling types.
Which naturally leads us to the more advanced stuff, serology and molecular methods, looking for antibodies or DNA.
Precisely. These aim to overcome the sensitivity issues of direct detection. Serological tests look for the horse's immune response to the antibodies it produces against the parasite.
Like the CATT.
Yes, the card agglutination test, CFE, specifically for T. evansi, is a good example. It's designed to be practical for field use, relatively quick. Good for identifying infected animals that need treatment.
Okay. And ELISA?
ELISA assays, another type of antibody test, particularly E.g. ELISA, are also very useful. They tend to be very good at correctly identifying uninfected animals.
So good for certifying horses as disease-free before movement or quarantine.
Exactly. They're valuable for that purpose.
Yeah.
Verifying disease-free status.
And then we have PCR, looking for the parasite's genetic material.
Right. PCR, polymerase chain reaction-based assays, detect Trypanosoma DNA, usually in a blood sample. Very sensitive in theory.
In theory. So these advanced tests, they're not perfect either.
No, they have their own challenges. PCR, for instance, can sometimes give false negatives. Maybe the parasitemia is so low, below the detection limit, or the specific gene sequence the test targets isn't present in all strains of the parasite.
Okay.
Conversely, you can get false positives if the target gene sequence is shared with other related trypanosome species that might not actually cause disease in horses.
Back to the identity crisis issue again.
It crops up everywhere. And some of the serological tests, while promising, still need more large-scale evaluation and standardization before they can be universally relied upon.
So there's still a critical gap, particularly for catching those really early or subclinical infections reliably.
There definitely is. It's a major focus for research.
Given all these pros and cons for each method, what's the recommended approach?
Often it's a combined approach, using multiple tests to increase confidence. For example, maybe screening with CAS in the field and then confirming with ELISA or PCR in the lab. Serial testing over time can also be helpful. It's about using the whole diagnostic toolbox strategically.
Okay, that makes sense. Use everything you've got. So we've covered the battle inside the horse, the detective work of diagnosis. Now, the battle plan. Diagnosis confirmed. What happens next? Treatment, management. And what's the big missing piece here?
Right. Once confirmed, management primarily relies on trypanosomiasis drug therapy, drugs designed to kill the parasites.
Are there effective drugs?
Yes, there are several. Common ones include dimetazine acetate, quinipyramine sulfate, and surramin. Some are curative, aiming to eliminate the infection. Others might have prophylactic or preventative effects, too.
So if we have drugs, why is it still such a huge problem? What's the catch?
The catch is multifaceted. Firstly, and this is the crucial missing piece, there's no universal effective vaccine.
Still no vaccine after all this time.
No. And remember that antigenic variation we talked about, the parasite constantly changing its coat.
Yeah, the moving target.
That makes vaccine development incredibly hard, but it also means drug resistance is a constant looming threat. The parasites can evolve resistance to the drugs we rely on.
Ah, so the drugs might stop working over time.
Exactly. It's an ongoing battle. This requires continuous surveillance to see if drugs are still effective in different regions, and it absolutely necessitates sustained research into new drugs, new therapeutic approaches, and, most importantly, that elusive effective vaccine.
So drugs are key, but not a silver bullet. What about supportive care? You mentioned the signs can be severe.
Absolutely critical. Supportive care is just as important as the specific drugs, maybe more so in some cases.
Like what?
Well, for that severe anemia, blood transfusions might be needed to save the horse's life. For the edema, the swelling, cold therapy, pressure bandages can help manage it.
And the neurological cases?
That's tough. Since direct treatments for the nerve damage itself are often unavailable, support is focused on managing symptoms, preventing secondary injuries if the horse is uncoordinated or down, maintaining comfort, providing a safe, padded environment.
Just trying to keep them safe and comfortable while hoping the drugs work.
Pretty much.
Yeah.
And nutritional support is vital too. These horses are often wasting away, have poor appetites. So highly palatable feed, maybe IV fluids if they're not eating or drinking.
Makes sense.
And for specific lesions like those skin plaques or genital lesions enduring, meticulous wound care is important to prevent secondary infections.
Okay. And finally, what about the environment? Vector control.
Yes, that's part of the broader strategy, and it depends on the Trypanosoma species, remember. For some of the Nagana group linked to tsetse flies.
Tsetse control or eradication program.
Right, where feasible. But for T. avansi, which uses other biting flies.
It's about broader biting fly management, stable hygiene, fly traps, repellents, that sort of thing.
Exactly. A much wider approach to vector control is needed.
So after all this, diagnosis, treatment attempts, supportive care, what's the likely outcome? What's the prognosis for a horse with trypanosomiasis? It sounds like it varies a lot.
It is highly variable. So many factors play a role, like the specific Trypanosoma species and even the strain. Some are much more virulent, more aggressive than others. The horse's own susceptibility is huge, too.
We mentioned donkeys are more resistant.
Generally, yes.
Yeah.
Donkeys and mules are often more resistant, can be asymptomatic carriers. Horses tend to be more severely affected. Even among horses, light breeds seem to develop more severe disease than, say, indigenous breeds that might have co-evolved with the parasite.
Interesting.
There's even some evidence that females might have slightly lower mortality rates than males. And, crucially, the stage of the disease when it's diagnosed and treated makes a massive difference.
Early versus late.
Exactly. The acute form, if caught late, can be rapidly fatal. The chronic form can drag on, leading to that severe wasting and, eventually, the neurological signs if untreated.
So timing is everything.
Timing of effective treatment is absolutely critical. The disease is generally progressive. If effective treatment isn't started, it's usually fatal. Early detection, early intervention, paramount.
And as we keep coming back to, if those neurological signs appear.
That's a grave indicator. It suggests CNS invasion, often irreversible damage, and carries a significantly worse prognosis, even with treatment.
Plus, the immunosuppression factor means they could get hit with other infections too.
Yes, secondary or opportunistic infections are definitely a risk, further complicating recovery and worsening the prognosis.
So, looking ahead, what does this all mean for the future, dealing with this complex enemy?
It means we need a truly holistic, integrated approach. You've got the complex parasite biology, the variable host response, the environmental factors like vectors. It all interconnects.
One health approach.
It's very much a one health issue.
Mm.
Future research really has to prioritize developing better diagnostics, rapid, sensitive, specific tests. Ideally, things veterinarians can use right there at the stall side for much earlier detection.
Catching it before it gets serious?
That's the goal. And concurrently, the search must continue for novel drugs to combat resistance. And critically, we need to crack the code on developing effective vaccines. Vaccines that can induce broad, long-lasting immunity against those ever-changing surface antigens.
It sounds like a continuous race against a very adaptable microscopic foe.
It absolutely is.
Well, this deep dive really brings into focus the core challenges of equine trypanosomiasis. Its shape-shifting nature, that identity crisis you mentioned, the sheer difficulty of diagnosis, and the ongoing struggle for effective long-term control.
It does. And the story of equine trypanosomiasis isn't just about horses, fascinating as that is. It serves as a powerful reminder, I think, of that relentless evolutionary dance between parasites and their hosts. And it really underscores why that one health perspective, integrating animal health, human health, and environmental strategies, is so absolutely essential for tackling complex global health threats like this one.
It certainly leaves you thinking about the bigger picture of disease control, doesn't it? And that constant, vital need for scientific innovation when we're faced with microscopic threats that are just so incredibly adaptable.